Hello, awesome staff of the Northwest Kidney Center with a special shout out to the Kent unit, our flagship 5-star facility. Today we're going to talk about the timing of when to start dialysis. That is, what are the factors that determine when a patient with chronic kidney disease would benefit from dialysis? Or phrased another way, why is our patient starting dialysis at this particular time rather than a month ago or 2 months from now? Of course, we don't want to start a patient on dialysis before it is absolutely needed, but we don't want to wait so long that they become seriously ill and have to start dialysis in the hospital, as often happens. Today's talk has 3 objectives. I want you to understand the estimated glomerular filtration rate in assessing kidney function, recognize the conventional criteria for dialysis initiation, and review special situations in which sometimes we start dialysis a little bit earlier or later, depending on the case. Let's begin by discussing some of the general principles that are involved in making the decision to start dialysis. For patients with chronic kidney disease, the decision to start chronic dialysis is made in collaboration between the nephrologist and the patient. In other words, it is very important for the patient to be on board with the idea of starting dialysis. Otherwise, compliance will be a problem from the start. If the patient has no symptoms, then dialysis won't make him or her feel better, and that will leave the patient wondering if the huge effort of dialysis is really worthwhile. There are some advantages to starting dialysis. For patients with advanced chronic kidney disease, there is a potential to improve uremic symptoms, which we'll discuss. We can also remove fluid, which can assist in the management of volume overload if they're not responding to medical management and diuretics. Additionally, dialysis allows for the prevention or treatment of severe electrolyte abnormalities, such as hyperkalemia or acidosis, a condition in which the blood gets very acidic. But of course, there are some disadvantages to starting dialysis. It's a huge effort on the part of the patient, and there is a significant cost associated with the procedure. So, in summary, the optimal time to initiate chronic dialysis is when the nephrologist and the patient agree that the overall benefits of kidney replacement therapy likely outweigh the risks and the burdens. If we fail on that objective, then usually we have to start dialysis on an urgent, unplanned basis in the hospital when the patient is very ill. Starting dialysis on an urgent as opposed to an elective basis is associated with increased morbidity, mortality, and catheter use. Obviously the optimal situation is that we can plan for the dialysis long after they've been approved for kidney transplant, they've had the chance to think about their preferred dialysis modality, and of course they have a functioning access in place. So a very important tool for identifying when a patient needs to start dialysis is something called the estimated glomerular filtration rate, or eGFR. So what is the estimated glomerular filtration rate? Well, it's an important tool for estimating a person's overall kidney function. And if you break down the term, so estimated means approximate, so it is not a precise estimate of kidney function, it is just a ballpark estimate. Glomerular refers to the filtering units in the kidney. So each kidney has about 1 million filtering units called glomeruli. And each glomerulus filters the blood and generates a tiny drop of urine that travels through a system of tubes to the middle portion of the kidney, and then down another tube called the ureter and into the bladder. Filtration rate is the rate at which the waste products are removed from the blood. More specifically, on a technical standpoint, estimated GFR, it's the volume of blood plasma per minute from which the kidneys are able to completely remove a waste product called creatinine. Now, practically, a normal glomerular filtration rate is around 100 milliliters per minute. And so most people use the GFR rate as an estimate of the total percentage of kidney function. So if someone has a GFR of 15 milliliters per minute, we generally interpret this as representing 15% overall kidney function. Now, there are some important considerations to recognize when using the GFR in determining whether or not someone needs dialysis. Most importantly, it is just one factor in determining when patients with advanced chronic kidney disease should initiate dialysis, but it is not the only one, and it's probably not the most important one. Second of all, there is no magic level or no minimum eGFR that provides an absolute indication to begin dialysis in the absence of symptoms. Some patients, especially those who are young and are otherwise fairly healthy, can do very well with an estimated GFR of, say, below 10 mils per minute and not need dialysis. As a general rule of thumb, we start dialysis if the estimated GFR is less than 10, so if someone has less than 10% kidney function, and patients have significant symptoms related to the kidney failure. We call these uremic symptoms. Sometimes we'll start dialysis if someone has less than 5% kidney function in the absence of symptoms due to the high risk of needing emergent dialysis at such a low level of kidney function. A couple other observations regarding the formula that you should keep in mind. First, there are several available equations that we use to estimate the estimated GFR. For example, the MDRD formula, the CKD-EPI formula. For clinical purposes, though, it doesn't really matter which formula is used. They are all estimates. Significantly, the formula is just an estimation, and there are times when it may not be very accurate. For example, if a patient has extremely low muscle mass, they may produce minimal creatinine. Say, for example, an elderly, frail woman with minimal muscle mass, she might have significant symptoms of kidney failure with a creatinine of only 3, whereas say a 30-year-old man might have those symptoms when his creatinine is 8. And in the case of the 90-year-old lady, an estimated GFR would be higher than her true GFR. So you may say, oh, she's got a creatinine of 3 and a GFR of 15, but in truth it could be lower than 10. We know there is no magic estimated GFR level or percentage of kidney function at which we should start dialysis. And this was illustrated in a study known as the IDEAL study. So the initiating dialysis early and late study. It was published in 2010 and was a randomized controlled trial comparing survival between patients initiating dialysis at 2 different thresholds of GFR. There were 828 patients with an eGFR between 10 and 15, so again, ballpark between 10 and 15% kidney function, and they were randomly assigned to start dialysis either early, when their GFR was between 10 and 14, or late, when the GFR was between 5 and 7. The median follow-up was 4 years. In this study, the median time to dialysis initiation was 2 and 7 months in the early and late start groups, respectively. But there was no difference in survival, cardiovascular events, infections, or dialysis complications between the 2 groups. So the authors conclude that there is no advantage to early over late dialysis. But it's important to recognize that this study has some major limitations. Most importantly, it permitted clinicians to initiate dialysis based on the presence of symptoms or volume overload, as well as the GFR. So it wasn't just the GFR that tipped people over into starting dialysis. And as a result, 76% of the patients who were assigned to the late start arm actually started dialysis earlier than planned. So in the late start group, the mean GFR was around 10. And in the early start group, it was around 12. So there really wasn't a big split between the 2 GFR estimates. But the whole point of this study is that there is no magic GFR associated with better survival or fewer complications with respect to timing of dialysis start. And this is why we use clinical criteria beyond just the GFR for deciding when someone needs dialysis. So as I just mentioned, when to start dialysis is not based just on the estimated GFR, but other clinical factors, including symptoms, nutritional status, and volume overload. And these factors really need to be considered together. Common symptoms associated with renal failure include nausea, vomiting, loss of appetite, weight loss, malaise or feeling really bad, and severe fatigue. Whether or not such symptoms should be an indication for chronic dialysis in part depends on the GFR. So you can use the clinical symptoms in conjunction with the GFR for deciding when to start dialysis. So for example, if someone has a GFR of greater than 10, so again an estimated kidney function of around 10% or greater, most patients' symptoms can be attributed to the kidney function but can be treated medically. Symptoms due to advanced kidney dysfunction are usually not disabling until someone has less than 10% kidney function. On the other hand, if someone has less than 10% kidney function, patients may develop symptoms like nausea, vomiting, weight loss, anorexia that we can no longer treat medically and should be treated with dialysis. Of course, the severity of symptoms depends a lot on the patient. I mean, younger, more robust patients can tolerate a lot more adverse symptoms, whereas older patients usually have lower tolerance and may need to be started a little bit earlier, again, depending on the severity of their symptoms. There are additional factors that we consider in deciding to start someone on dialysis. For example, declining nutritional status, persistent or difficult to treat volume overload or fluid retention, fatigue and malaise, as well as confusion. As I mentioned recently, common symptoms of uremia include anorexia or loss of appetite, nausea, weight loss, and poor oral intake. In fact, loss of appetite is usually one of the first uremic symptoms. So I always ask my patients when they come into the clinic, how are they eating, how's their appetite? More specifically, loss of appetite for meat is very common among patients who have chronic kidney disease. There was an observational study of 90 patients with CKD who received no dietary counseling or intervention, and that study showed a direct correlation between the creatinine clearance, or the percentage of kidney function, and how much protein they were eating. So people who had more than 50% kidney function on average ate essentially a normal amount of protein, 1.1 grams per kilogram per day. Those who had between 25 and 50% kidney function ate only 0.85 grams per kilogram per day. Those who had estimated kidney function of 10 to 25% ate even less. And finally, those who had less than 10 ate about half as much protein as normal. One limitation of relying on appetite as a symptom or anorexia is that the symptoms of anorexia and malnutrition may be insidious. They may develop very slowly over time, such that the patients don't even notice it. In fact, a lot of patients say, yep, I eat fine, no problems, appetite's fine. So that's why we usually monitor weight and serum albumin. We try to correlate the two. So if a patient comes in, even if they say they're eating well, but their weight is low and their albumin is falling, that's a concern from a nutritional standpoint. Now, it's also important to recognize that not all nausea, vomiting, and loss of appetite reflect uremia. Now, there are other causes in this population. So, for example, a lot of diabetics get something called gastroparesis, which causes them to throw up a lot. A lot of medications can upset the stomach, including oral iron and the dietary phosphorus binders. Acidosis, or a condition in which the acid accumulates in the blood, can also cause nausea. Another common indication to start dialysis is volume overload. Most patients with advanced chronic kidney disease retain sodium in water, potentially causing swelling, elevated blood pressure, and symptoms of heart failure. Of course, we use diuretics to treat volume overload in this population, but sometimes the diuretics don't work. They're not absorbed well, and patients become persistently volume overloaded, for which dialysis needs to be started. Other symptoms that suggest someone may be ready for dialysis include fatigue and malaise. So we all know what fatigue is. This is probably something you're experiencing right now as you watch this video. Malaise comes from the French word, the same name. Mal means bad and aise means comfort, so bad comfort. Basically, you feel really bad. So it's an indefinite feeling of debility or lack of health, often indicative of or accompanying the onset of an illness. And it's common in patients with chronic kidney disease, even at relatively early stages. However, people can feel bad for lots of reasons other than just uremia. If we can't find any other reason for generally feeling bad, then we usually attribute fatigue and malaise to uremia and start dialysis, and most of the time it makes people feel a lot better. In advanced stages of kidney disease, uremia can cause confusion. It's not common because usually we start dialysis before this develops, but it certainly can happen, and patients come to the hospital confused, and dialysis initiation usually helps. Other reasons to consider starting dialysis include severe metabolic abnormalities. These include metabolic acidosis, high potassium, high phosphorus levels. So, medical therapies are often effective in managing these problems, but if they are unsuccessful, then that increases the rationale for starting dialysis. So patients with CKD can oftentimes develop severe metabolic acidosis, where the acidity of the blood increases, and that can make people feel horrible. High potassium is also a concern, despite dietary restriction and medical management, and that can cause cardiac arrhythmias. And hyperphosphatemia, again, we try to control it with use of dietary phosphorus restriction and the use of binders, but sometimes we are unable. So what about patients who have really advanced kidney disease with less than 5% kidney function or an eGFR less than 5 mils per minute? Well, in general, most of these patients will have uremic signs and symptoms. They may deny it, but if you start asking or probing them or examining them, you will find some. And in general, we recommend starting these patients on dialysis because of the high potential of developing a severe complication associated with their advanced kidney failure. Okay, let's look at some special cases in which we start dialysis maybe a little bit earlier than usual. In some patients who demonstrate a rapid decline in kidney function, it may be reasonable to initiate dialysis earlier or even before they have symptoms. And that's because delaying dialysis may increase the risk of their getting hospitalized or needing emergent dialysis. Now, the loss of kidney function is variable and can occur quickly in up to 20% of patients. So usually it's gradual, but sometimes, patients' kidney function, rapidly declines. And risk factors for this include cardiovascular disease, particularly heart failure. So when patients come into the hospital with severe volume overload and they get diuresis, their kidney function tends to rapidly get worse. Diabetics and patients who have cancer are also at increased risk for a rapid decline in kidney function. And again, sometimes we start them on dialysis earlier because it's very difficult to time exactly when they're going to need dialysis. Now, indications for starting dialysis in the elderly are the same as in the general population with CKD, but it's important to recognize that there's no evidence that initiating dialysis earlier in older patients is beneficial. And interestingly, in older patients, treatment with dialysis versus conservative therapy, that is just managing their symptoms medically without dialysis, has been shown in some studies to lead to longer survival, but not in other studies. And so essentially it's an individual choice as to when to start an older person on dialysis, but we don't rush to dialysis just because they're older or frailer. What about patients with multiple other medical problems, so-called comorbid conditions? Well, there is no evidence that patients with, say, diabetes or cardiovascular disease benefit from earlier initiation of dialysis. Although patients with multiple medical problems are more likely to end up starting dialysis in the hospital and receive dialysis in an unplanned emergent situation. Now, patients with severe comorbidities like end-stage heart failure or liver disease or frailty or severe functional or cognitive impairment like dementia, they do not do very well with dialysis, and there's certainly no evidence that starting them on dialysis earlier is clinically useful. How about peritoneal dialysis? Well, of course, the indications for starting peritoneal dialysis are the same as, for those who are starting hemodialysis. But sometimes we start dialysis a little bit earlier in our peritoneal dialysis patients, and that's because when they start to feel bad, well, then you've got to get them to see a surgeon. Then they have to undergo the surgical placement of the peritoneal dialysis catheter, and then they have a very sore abdomen for a week or two, so you don't want to do the dialysis right away. And of course, they had to participate in the peritoneal dialysis training, and so you don't want to wait until they feel so bad and have so much fatigue or confusion that they can't participate in the therapy. So sometimes we start peritoneal dialysis patients just a little bit earlier than our hemo patients to make sure that we are able to coordinate the placement of the catheter and the dialysis training that's involved. Other factors that affect the timing of dialysis include the attitude of the nephrologist. Basically, there are substantial differences in practice patterns between individual nephrologists across the country and across the world. People just have different opinions about this, and so that definitely plays into all of this. And then finally, the timing of referral to a nephrologist. So if a patient comes to the nephrologist very late, say when they have less than 20% kidney function, sometimes there isn't enough time to provide all the proper education regarding dialysis modality or get a fistula put in, particularly if they have symptoms attributable to their kidney disease. Thank you for your attention so far. Let's now summarize what we have learned. First, nephrologists and the patients have to mutually agree to start dialysis. You have to have buy-in from the patient. And in general, if they feel well, it's a hard sell to tell them that they need to start dialysis. And so oftentimes we wait until they don't feel so good, and then they recognize the benefits of dialysis, particularly after they start. The glomerular filtration rate, it's a very important tool for assessing the level of kidney function. Think about it as a percentage of kidney function that someone has. If someone has a GFR of greater than 10, again, ballpark 10% kidney function, usually we can medically manage the complications and symptoms of kidney failure without dialysis. But if they have less than 10, between 5 and 10% kidney function, we generally start dialysis if they have signs or symptoms of renal failure. And as we discussed earlier, these can include nausea, vomiting, loss of appetite, weight loss, severe fatigue, malaise, or signs of fluid retention. If they have less than 5% kidney function, it's a good idea to start them on dialysis because of the high risk of needing urgent dialysis in the hospital when they have such a low amount of reserve kidney function. Unplanned dialysis is usually started in the hospital. It's associated with high rates of catheter use, increased overall morbidity, as well as mortality. So we really want to start dialysis electively on the outpatient basis if possible. Sometimes we start patients with a rapid kidney function decline earlier on dialysis so that we can prevent a hospitalization or unplanned dialysis treatment, even if they don't have overt symptoms attributable to their kidney disease. And finally, for peritoneal dialysis, usually referred a little bit earlier than hemodialysis just because of the time involved in referring them to a surgeon, recovering from peritoneal dialysis catheter placement, and making sure that they still feel well enough to participate in peritoneal dialysis training. Okay, let's see how well you paid attention. Is there a specific glomerular filtration rate at which dialysis should be initiated? So the answer is no, for the most part. Usually, however, we start dialysis when someone has less than 10% kidney function, or as I mentioned earlier, if they have less than 5% kidney function, just because of their very limited reserve and the potential to get sick and end up in the hospital. But the take-home point that I want you to remember from this is that GFR is one of the tools that we use to decide whether or not someone needs dialysis, but it's not the only tool. Question number 2, name three uremic symptoms. Excellent. So the picture probably gave it away. Nausea, vomiting, anorexia or loss of appetite, fatigue, and malaise. Question number 3. Name 3 physical manifestations or signs of renal failure. Excellent. So fluid retention or swelling, shortness of breath. Pericarditis, that's inflammation of the lining of the heart called the pericardium. Weight loss and confusion. Question number 4, what did the IDEAL study show? That's right. So there was no benefit to early dialysis initiation, so GFR above 10 as opposed to below 10. So again, we don't rush to dialysis just based on the GFR level. Final question, who can be reasonably started on dialysis even if they have no or only minimal symptoms? Excellent. So patients who have a GFR or estimated kidney function of less than 5%, again, they have very little reserve function and are at higher risk of decompensating and ending up in the hospital. Patients with a rapid decline in kidney function. If the kidney function is rapidly getting worse, follow the trajectory, start them on dialysis before they have to be started in the hospital. Patients who are on peritoneal dialysis or starting peritoneal dialysis, again, you don't want to wait until their symptoms are so severe that they wouldn't do well with the surgery, waiting a couple weeks for them to recover after the operation, and they have to be thinking clearly enough and have the energy to participate in the peritoneal dialysis training. And then finally, patients who have severe electrolyte abnormalities like hyperkalemia. They may feel fine, but hyperkalemia, of course, is associated with potentially life-threatening arrhythmias. This concludes the August 2023 in-service for the Northwest Kidney Center. Thank you for everything you guys do and for your attention. This is Andy Birkenbrough signing out until next month.